everyone, and welcome to day 2 of TIO 2026. Really exciting session you've joined for. In this session, we're going to have a live case, and it's going to be a live intracardiac echo-guided occlusion of a left atrial appendage, which is very interesting because, we're moving these procedures from being GA and TE guided to now less invasive. And so we're going to have a great live case from Ollie de Backer in Copenhagen. Let me introduce you to my panel. Today, we have some real experts in the field and good friends. Guillaume from Bordeaux, Nicolas van Mieghem from Rotterdam. Hopefully, we're going to have Karim join us sometime during the case. He's also an expert in LAA closure, but he got caught up in a case in his own center. And obviously, like I said, our live case will come from Ollie de Backer in Rigshospitalet. Before we hand it over to Ollie, I wanted to start a little bit with a poll, just to really understand from all of you how much has the recent data impacted your practice and your thoughts about LAA occlusion. As you know, there have been a number of studies, and at this ACC and in New England Journal of Medicine was one of the largest randomized studies in LAA closure, the Champion AF study, which randomized patients to transcatheter closure with a Watchman device versus continuing medical therapy with a DOAC. And so it showed non-inferiority. There are some, I think, as in with everything, the devil's in the details, and there are some details about the study that, some people have questioned. But again, it did show non-inferiority. So here's the poll, and we could bring up the poll for everybody so they can see the questions. After this data, do you feel that LAA closure should be reimbursed as an alternative to oral anticoagulation drugs? So if a patient comes in and says, I don't want to take DOAC, not because they've had bleeding, they just don't want to take it, should this be now an alternative and should be reimbursed? Or B, should only be reimbursed when oral anticoagulation drugs are contraindicated? Or C, should never be reimbursed because it's expensive and the randomized data is not compelling enough for us to use this therapy? Or D, should it be compared to surgical LAA closure in a randomized trial? So I'm going to give you a little bit of time to think about that and answer that. And maybe after we present today's patient, we'll come back and look at the poll results, which I'm interested to see how you guys are thinking about this before we go to the live case. So I'm going to start with showing you the patient we're going to be treating and talking about the case, and then we'll go live. So let's go to the next slide. So our patient today is 76 years old, a male, in permanent atrial fibrillation, has also hypertension and pre-diabetes. His BMI is 22.4, has a CHADS VAS score of 6, so pretty high, a Hasblad score of 4, had a previous subarachnoidal hemorrhage on DOACs, and has also cerebral amyloid angiopathy, which we know is also associated with the increased risk of bleeding. So, I think in my mind, this is the really perfect candidate for an LAA closure, someone who is high risk of having a stroke and really can't take DOACs because of bleeding. So depending on how you work and your workflow, you may do CTs before or not, and that could be a whole discussion we can have later. But in Rigs, it is their standard to do CTs for all these patients. And here you see the measurements. You have a perimeter of 88.7 with a perimeter derived diameter of 28.2, minimum max diameters of 25.7 and 30.7. And then at 8 millimeters, you see a second measurement slightly smaller. Okay, next slide. Here you see the optimal view. So that's also the advantage of doing CT, is that if you're going to do this ICE-guided in a patient kind of awake with moderate sedation, CT gives you all this information. It gives you accurate sizing. It can exclude LAA clots, and it gives you the projection, the best projection which to work in for an optimal implantation. And in this patient, it's an RAO 50, coronal 10. Next slide. Here is the LAA 3D model. And here again, helping you understand kind of what the anatomy looks like and having a better understanding of, where do you need to start deploying your device, how challenging it's going to be. We talk about different forms of LAA and morphologies, and here you get to see that very well. Next slide. Then also the CT can be very helpful in planning your transseptal puncture. With any left-sided procedure, whether it's LAA or mitral, the transseptal puncture can really make this procedure easier or more challenging and can often be the key to success. And so, yeah, it looks like, Ollie's planning a posterior inferior puncture because that will give him the best trajectory to the left atrial appendage. Next slide. So his procedural plan and the plan of the team at Rigs is to do a 3D ice-guided LA closure under local anesthesia, so awake patient. They're going to use 3D ice with a Variside Phillips system, and we'll show you that system in a second. Right femoral vein access. They will do a transseptal puncture with the VersaCross Connect 2 system, and they're planning to implant a 30-millimeter Watchman Flex Pro. Next slide. So the Watchman Flex Pro is the latest device from Boston Scientific. It really continues to evolve the Watchman design for LA closure. It does allow for full recapture. It does have this new coating that's optimized for healing. These 3 radiopaque markers that increase the fluoroscopic visibility when you're in the sheath to try and understand where the device is. It also has this sort of rounded tip because you are pushing this device out into the left atrial appendage, and that tip really will depend whether you traumatize the left atrial appendage or not. So this, device has become certainly in the United States, one of the more predominant devices being used. Next slide. It comes in multiple sizes from 20 to 40 millimeters, and this depends on the size of the left atrial appendage, but also the depth of the left atrial appendage, because the larger device, the more depth you need. And so remember here, we've chosen a 31 millimeter device, which is larger than the ostium and where we're going to anchor. And really what you're trying to do is make sure that the device anchors and you want to look for 10 to 30% compression of the device before you release it. Next slide. So to get the device there, you could either use a fixed dilated delivery system, or you can use a steerable delivery system. So Boston Scientific now has this whole array of devices for transseptal puncture using radio frequency, including then having a steerable sheath to allow you to be more coaxial. So I think hopefully we're going to be seeing this Watchman True Steer sheath, which, as you can see, has this bidirectional steering. It has markers as well, so you can see where it is. And kind of the advantage of this is into the steerable sheath, you can put a dilator and a radio frequency wire. So you cross with the wire, dilate with the dilator and the sheath, and now you already have your sheath in there in order to be able to get coaxial with the left atrial appendage. Next slide. Here you see just some videos, obviously showing how hopefully with this sheath, and we'll see that today, that having the true steer sheath is going to allow you to be, the operators to be more coaxial. And coaxiality always, with all structural heart procedures, makes your life easier and makes deployment a lot more predictable. Next slide. And this is what I talked about earlier, is this connect system, which is essentially the dilator and this wire that can fit either into one of the Watchman fixed curves. So they have a fixed curve system that's not steerable. That's a single curve or double curve. And you can use this dilator and wire in that, or you can use the dilator and wire into the true steer system. So the steerable system. So it gives you this flexibility. And I think the big flexibility is use one system to do transseptal puncture and then to deliver the device as well. Next slide. And then Ollie is going to take us through the usage of the VeriSight Pro 3D ICE probe. This is one of 3 now 3D ICE probes that are available around the world. The VeriSight comes from Philips. It has a knob to keep your steering. It has 2 steering wheels on it that allow you to go anterior, posterior, and right versus left. But most importantly, this is 3D ICE. So for those of you who are used to seeing TE pictures, where you can do biplane and 3D MPR, this catheter, which is 9 French, can essentially do the same thing. 10 French, sorry. Will give you 3D pictures. And yeah, there are some data. I just wanted you, more than the data, you to see what these pictures look like before we go live to the team to actually see them in a patient. But you really are, these are all pictures taken with an ICE catheter, so you really do see very complete dimensions and workability of this ICE catheter. And I'll let Ollie explain where he places this ICE catheter as he does the procedure. So that's our case. Let's pass it on straight to Ollie the backer and his team in Rigs. But let's just look at before that what you all thought about Champion AF. So yeah, maybe I'm not surprised a little. I think almost half of the audience thought that it should only be reimbursed when anticoagulation drugs are contraindicated. 1/3 thought that it should be an alternative to anticoagulation. Very few thought that it's too expensive and there's no compelling data. So I think overall, most of the audience are feeling that there's a place for LAA occlusion. How large that place is going to be seems to be there's some differentiation. Some would still like a randomized trial, but I think most people believe there's an important role for LAA closure in patients, either as a alternative to oral anticoagulation, but a preference is for those where it's contraindicated. Great. So I think we go straight to Ollie and his team in Rigs. Ollie.
Azeem, hello. My name is Gintas Belauskas, and Ollie is right next to me. Let me briefly introduce the team. Do you hear us, by the way? You hear us? Connection okay?
Maybe not. Let's wait. I'm not sure.
Yeah, we hear you now. It's a little soft, but I think it may be on our side. We'll increase the volume, but we do hear you. Please go ahead.
Okay, Gintas Belauskas, my name, Ollie the biker. Next to me, we have 3 nurses next to us, Ida, Barbara, and Lonnie, I think. Oh, she's gone now. Okay, it's already late, so we're like on staff. That's all right.
Johanna.
And we have a couple of fellows, Johanna, and we have also Arif, and then we have our expert imager on ICE, Nils Wallstrup, here with us today. So, Ole, what have we prepared? Let's see, maybe walk us through the equipment. There was many new stuff.
I mean, we haven't done anything. We were waiting here. So we have done just two venous punctures. Yes, 2 venous punctures. There's a 10 French sheet for the ICE. This is the VeriSight from Philips. And then the 3D ICE. And then we have just a 6 French venous access in this other room where we're going to do the delivery of the LA closure device. Then indeed, very important, I won't make it long, what devices do we have? So this is the true steer sheets, indeed. What you see here, maybe you zoom out. Yes, here you go. This is the full true steer. So the beauty is that with this wheel here, now we can steer. You can flex it a lot, or you can unflex, retroflex. So I leave it in a neutral position. This is the dilator that comes in the box of the true steer, but we're not going to use this. So this one out. And what comes in place is the Versa Cross Connect. And what is the Versa Cross Connect? That compromises this shapeable dilator, so I can really shape it almost like clay. I can make it like a big curve or small curve. I typically give it a 90-degree curve. That goes in, so maybe you can do that into this true steer, so we can flush it maybe first here.
It's already flushed, but we can reflush it,
right? Because we had a couple of minutes here laying this, so we can flush it. Yeah, and now we get this Versa Cross Connect dilator in. So that's how we do it. And then the next thing is, in the Versa Cross Connect box, there's not only the dilator, there's also this wire. So that's that RF wire, which looks a bit like a safari wire, and that's to make the transseptal puncture. So everything all is in one. We don't need any other transseptal puncture kit or sheet. Yes. So let's continue now. So the 3D ICE is in place. This is the wire of the Versa Cross Connect, which goes straight into this 6 French sheet, venous access. If you follow now also on fluoro, yes, you see the wire goes straight up to the vena cava superior. You see the eyes probe there in a classical position. Niels Weilstrup is our eyes imager. Depends. If we do 2D eyes assisted LA closure, this we can manage ourselves. As an implanter, we steer both the 2D eyes and the implants. But if we use 3D eyes, I mean, for me it's too complex to control, and the eyes catheter and the console and the implants, we ask definitely for an imager. So now this wire, as you see, the Versa Cross Connect wire is in the vena cava superior. Now this true steer with the Versa Cross Connect dilator goes onto this wire, yes?
Yeah.
All right, so
I hold the wire.
Maybe, Quintas, it's important, these things, they are aligned.
They are aligned, yes. Aligned and connected and
all right,
closed.
good. So I go up.
Yeah. Yeah,
So I'm going up. I'm interacting a little bit with the eyes there. Okay, good, but that's fine. So what now? I will zoom a little. So you see here the two flush ports, or the flush port of the true steer, and this, what would you call it? Like
some kind of small
handle,
indicator marker.
Indicator of the Versa Cross Connect dilator be pointing.
How do the dilator kind of?
Yeah.
So now I'm pulling in the wire. You see, I'm pulling the wire completely into the Versa Cross Connect dilator. Even that small tip, you see, that has to be completely in. All right. So now I want an infero-posterior puncture. Always as inferior as possible. I'm not so picky on my posteriority, but especially inferior. So I'm gonna go now clocking clockwise to around 4 or 5 o'clock with the flush port. And now I'm coming down. We see maybe also the eyes. Yes, you see the interatrial septum. And on the right-hand side of the eyes, you see actually the superior part. On the left-hand side of the eyes, you see the inferior edge of the fossa. Yes.
It's not a very big fossa here. Yes,
it's not a big fossa.
It's like we don't have a lot of choice.
No. So I'm coming down.
I'm gonna try to be inferior.
I'm coming down slowly. 5 o'clock with my flush port. Yeah, we have some sending here.
I will rotate the C-arm to RAO 30. This gives a little bit better perspective on the...
I think you can do a bit more inferior.
I can go a bit more inferior indeed. Let me check.
And a bit more posterior.
So we see you dropped on the fossa.
Yeah, no.
Oh, now you're very inferior. So
look, now I'm very inferior. That's great. You see there the tenting inferior. That's what we love. And I'm sure I'm also...
You're not that posterior.
I'm not that posterior indeed. So that's maybe I can go. That's also true.
So now we use the X-plane.
I go a little bit more posterior.
That's nicer.
Maybe this. Yeah?
So yeah, now you're inferior.
Maybe you take the fluoro now.
Yeah. Fluoro live.
Okay, fluoro live. Let me check on the eyes again. If you're happy with your tenting.
Let's go down to the inferior. Oh, where did you?
You sure you can go too inferior now?
Yeah, now I think you've probably gone too inferior.
Maybe. I'll push a little bit up. Well, if I'm too inferior, I can go up again.
Yeah, I think you should go up again.
All right, I can go up again. Yeah. All right, I will go up again. That can happen. So normally that shouldn't be a big issue. So now...
Oh, here you go. So
okay.
Are you happy with this? This is inferior.
It's actually a pulled, yeah. So I'm actually still, let's see if we're posterior enough also.
That's
probably it's okay. I would say.
Have a look. So...
No, I didn't burn yet. I'm waiting for a good response here. Well, it's important to have a good transseptal puncture, so...
So we're doing the X-plane, so we have anterior, posterior on the right side, and superior, inferior. Now I don't see the camera. So there's your posterior.
Okay, I can go up again.
Yeah, no, hang on. Just stay there as well. Just see if I can find it. I'll go down.
Can I get the screen a tiny bit more to the right place? Because
what do you think?
So I see the catheter there, Ali. It looks a little too inferior, maybe?
Well, I mean, honestly, I mean, if somebody says to me it's almost too inferior, that's typically the right spot to do the transseptal puncture for an LA closure.
That's you like it then.
We really
okay.
Okay. That's really the best.
I like that
for an LA closure. It's almost when you're too low.
Okay.
So shouldn't we just do it?
So you do it.
Yeah. Okay. Good. All right. Is it connected? The Versa Cross Connect wire is connected. Yeah. So now you see I moved that small black dot there. If you see on the fluoro go live, I moved that small dot just out of the sheet. Yes, you see that there. That's important because as soon as I have a pedal on my foot, as soon as I give energy and I put my foot down, I will push this wire out. Yes, maybe not that much zoom in. I don't like it.
Yeah, it's okay.
Yeah, all right, good. So you're still happy? All right, this is live.
This is live.
So I'm gonna give energy. Yeah, I gave energy.
And you're across.
And I'm across. Yeah, good. All right, then we zoom further out. Give me a little bit of craniality maybe there. Because if we go cranial a tiny bit, we separate the pulmonary vein and the left atrial appendage the best. So now my wire is, this is better. Now my wire is going 100% in the left upper pulmonary vein. That's great. So I'll push myself through.
Yeah.
Now I do this repetitional 3 times. So you see my mindset is really, if you think you're almost to inferior, that's the spots where you have to do transseptal puncture.
That's a good place.
Look, I mean,
Right.
yeah, that's a good place. I mean, you want to go as really on the inferior edge. So now, Niels, you can cross with the eyes. Of course, that's easier said than done, because that's not always as easy to cross with the eyes probe.
Yeah. Do you have any tips for us on what to do to cross?
Yeah, there are a couple of tips. So what you can, well, you saw us already, like I will repeat it. So what I do is this year with this 14 French delivery system, I go 2-3 times across. Let's get full heparin also, please.
It's done, it's done.
Yeah.
It's done, okay. Then you can look on the fluoro, but you can also look on your eyes where you see your, actually your wire. So I have to say it also depends a little bit on which eyes probe you use. This is not necessarily the easiest probe, to be honest, to go across. We typically do the eyes probe. We use a Viewflex probe. No, you're not across. That's you're bending it.
Yeah.
But
one of the things I do, Ollie, is I change more to an LAO view, and then I try and follow the wire in LAO, and it just gives me a better direction of pointing towards the septum.
Yeah, we do sometimes indeed LAO, REO. We switch a bit, but to be honest, not too much. I think you're a bit too high. Or
went somewhere, but no.
That's probably in the RV.
Now I'm across.
Coronary sinus.
Okay. Then
coronary sinus, yeah. Yeah.
I think you have to go a tiny bit lower, because if you saw where we crossed, you know, like we
start a little lower.
Yeah, maybe go together now.
I'll pull it back.
So this is often for me also, Ollie, the most challenging part is crossing. Even when I do mitral valve in valve and I've made a nice big hole with a 12 or 14 millimeter balloon, it can be a challenge to cross. You just gotta take your time. And usually I think you're right, we start too high. So it's often what I'll do is come a little lower and then try and follow the wire.
Now I'm across, yeah.
Now we're across, it seems.
Yeah.
Yeah. Okay, then I will go REO, because then we split the... By going at REO, we know that on the left-hand side of the screen, yes, there is the pulmonary vein. So now it's in the pulmonary vein. That's where we want to have it. And so this is 12 o'clock on the screen. And on 1 or 2 o'clock, you will know that the appendage is. So now I'm going across. Wait, let me go a little more AP. Yeah. So now you see I'm still with that true sphere and versa cross. I hadn't to change anything. All right. Now we take everything out. Wire inclusive. Yeah, all right, good. Everything else.
All
right, I let it bleed back. Now a 6 dilator and a J-wire and maybe a pigtail. Yeah. So that's the beauty. We don't have to change anything. We just go across, do the transseptal puncture, and immediately we have the delivery system in place. So now we're going to introduce here a wire. Yeah. So full heparin. I just ask again to be 100% sure. It's given. Good. All right, so the implant view was REO 50, caudal 10. And to be honest, I mean, many people don't believe or don't use CT. I know that for LA closure. But if you do it, I mean, this is one of the most great aspects of it, that you have that optimal implant view. And that really, really, really helps you out in a lot of cases, I would say.
Yeah.
So now also you see we have the eyes there. So I know I'm probably a little bit too deep in the left atrium. I pull a little bit back. I go counterclock. Yes. And then in fact, I expect my left atrial appendage there around 2 o'clock. Okay, the patient's taking a deep breath there. I'm pulling a little bit back there even. Yeah, I'll retroflex a tiny bit there, maybe. Yeah, and now if we push it, look, now I would expect I would go almost straight into the appendage there. I was not right. Yeah, this is in the appendage. I'm quite sure. 95%. Go with the wire forward, please.
So you're in the appendage there,
Yes,
yeah?
yes, that's also what I expected.
Wire side.
All right, then now I push the delivery system forward.
Contrast.
Yeah, all right, like this. Yeah. Okay, good, that's it. Now we have our almost REO 50, yeah, caudal 10. Yeah, that's great. I will make Mac 1 up. And this is, you will see on the eyes too. The eyes proof, we don't do a lot of crazy navigation in the left atrium. I don't think that's appropriate to do. It's just we kind of have it here in the left upper pulmonary vein. Let's see if he's in the left upper pulmonary vein or even in our
I'm in the
LA.
atrium now.
I think you're in the appendage, maybe even, you know.
No, I don't. Well, am I? Because
Let's see.
I'm ready to inject.
I'm just trying to measure it.
Yeah. Yeah, I think you're in the appendage with your
Okay,
eyes.
I'll
You
go
see
up
that?
back. Yeah, hang on. I'll just see.
So then I think you just have to retroflex.
Yeah,
You have to pull a little bit back, retroflex a bit. Yeah, like that.
It's okay. I'll go in the vein.
Yeah. Okay. Maybe can we see that? Now you're in the pulmonary vein. Yeah. Okay. Can we see that injection?
Yep. Coming online.
Yeah. Then we see it live. All right. Good. Well, indeed, it's a big appendage. I mean, we know from the CT that it tapers to the ostium to almost 30.5. So a 31 device we definitely need. I think it tapers a lot on the other hand. So it's not the easiest appendage, but I think 35 will be too large, I think. 27 is for sure too small. So 27 may be good. And then not a too proximal implant, I think.
31.
31, yeah?
Yeah.
Yep. Yes. And then also here the sheet. So
tell us a little bit, maybe this morphology, the challenges of treating this type of morphology.
Yeah, look, I mean, if we let it replay, what is a challenge about this is that it's a wide open tapering ostium. Yes, you see it goes like a very tapered where the spichtel is. It's very tapered, but then to the ostium, to the common ridge, it tapers very much open. So that's typically not the easiest anatomy. And that's why typically if you would oversize too much like a 35, you would have a lot of shoulder. So the device would be able to anchor and sit in, but you will have a device that sticks out quite a bit in the left atrium. And we know if you go for too much shoulder, you also risk leak below actually the skirt, so of that device. So now actually what we can do with 3D eyes is also do some sizing. I don't know if Niels is already into that aspect or not. Also,
Ola, as you're doing that, would you would you like to go deeper with your pigtail in the LAA?
I don't want to go deeper.
Pretty deep.
No, I'm already pretty deep. So if I go deeper, I may perforate something. What I can hear in this image, you see I'm pointing to 2 o'clock. Maybe I prefer more my sheet 1 o'clock, and that's the beauty. I will show you here live. And if you look to my hands with a steerable sheet, so look, now I'm maybe not 100% happy with my coaxiality. So first of all, don't forget to give enough anterior torque with the sheet in general. Typically it's flush port 12 o'clock, and you see in fact now the coaxiality is already much better without using my steerability. But if I give retroflex here, you see you can retroflex really a lot, or I can flex with the sheet. You see it, how it moves on live. So you can really optimize the coaxiality, and that's beautiful. I mean, it's a really fantastic sheet, I would say. I mean, it's going a little bit deep even. We have to be careful because the patient is taking quite some deep breaths there. Okay, good. I think we move on as well, because it's not good to have a sheet standing too long and the patient is,
from the left atrium.
Look, now coaxiality.
And what do you keep your ACTs for this? Above 250?
Between 250 and 350, yeah. Yes, it was around 300, I think. So let's take the device if you're happy. So you see now my coaxiality, I think, is perfect. and we're taking the device. Also, Niels, you showed there, yes, you had around 27 by...
So 27 for 25.
By 25. So then the 31 device is also perfect there. Okay, we're gonna take this spatial out.
We're gonna keep it low, yes.
Yeah. All right, so now I keep it low. The device has been flushed and is in the catheter. Yeah.
We flush.
All right, you flush. So it's running to running connection. It's bleeding back from the sheet. Device goes in. Now I go slowly forward. And I keep my sheet, you see, I keep my sheet anterior flexed with the flush port almost 12 o'clock.
Okay.
Because an appendage is always anteriorly positioned. So typically it needs some anterior turn. So that's what I learned from using this steerable sheet. Don't forget your anterior turn on the handle itself, and only then, if you it's more for the finesse, for the real gentle modifications that you use this steerable function. Yes. So okay, let's now do step by step. So how do we do this Watchman flex? So we go. You see the device is coming. We have this ring, distal ring on the fluoro. So we bring the distal ring to the distal ring of the delivery sheet. Yeah, that's here. As soon as they are matching, I hold with my right hand the device, and I will bring back the true steer and make a click. Now they're clicking. They're clicking.
That's basically unchanged from the past, right? This is what we're used to do, I guess.
Correct.
That is exactly the same. Yeah. Can I see the injection again? Then I look for some bony structures. Yeah, you see the rib, the bottom of the rib, the top of the rib I shouldn't pass because that's out of the appendage. So I'm pretty good there, I think.
You're already deep there, yeah.
I'm pretty deep there already. So I will unsheet now my ball shape of the device.
Oh, careful.
Of course, I'm going careful and I go always slow. So here, this is my kind of ballish shape. I want to see now on echo what I have and how deep I am. Just go 2D.
Okay.
Don't give an injection yet. And, there. So this is a great image. You see the circumflex artery there also in the left corner there with the cross now indicated by Niels.
Yeah.
So if you are a centimeter past of that,
at about 9 o'clock,
that's typically good. Yeah, indeed. So now I continue. Typically what I do is push the device a bit out and at the same time I unsheet. It's very rare that I only push the device out or I only unsheet the device, or I must be very, very deep into the anatomy. So typically it's a combination of both. So now I'm pushing a little bit of the device out, unsheeting a little bit, now pushing the device a little bit more out, then unsheeting. Yeah, like this. And you can do it very controlled and calm. Yeah, here you go. And then I make that well. You see, you make that well in the device. There. So let's see what we have. It doesn't look bad on the first glimpse. I mean, we don't have too much protrusion of a shoulder. That's a great thing aspect. I'll maybe give a little bit of retroflex, or I hold my counter to core torque. I take some distance. Okay, so let's make are you ready for an injection, Gintes, or not?
Yes.
We can make I will close this here.
I'm good.
Wait, fill the sheet maybe first.
It's filled.
All right, good. Then you make an injection. Yeah, beautiful. I mean, I like this. This is great. This is not much shoulder or no shoulder inferiorly, and we go as much as possible. We don't cover the full common ridge, but that's impossible. I mean, in this anatomy with a wide open tapering, and I didn't even tuck on this device. What is also new on this, this Watchman Flex device is really a great device. I would say it's extremely conformable. That's what it makes such a good device. And what is new also on this device, you see these 3 markers. So that's actually the crown that I made. There's a little bit of parallax in that crown. Let's see how we get the parallax out. If we get it out, not really. But then I will do some tuck tests here. Yes, I will make some distance. Patient is making deep breaths, to be honest. Wow, he's really, this just because he takes a deep breath, you know.
He's doing his own tech test, I think.
He's not sedated at all. It's purely local anesthesia. Did he get some fentanyl? No, he didn't get anything. So it's weird. But the guy fell asleep. So, okay, fine. That's because of your talking, Azeem, in the beginning. No, I'm just joking. So I'm gonna do
so calming, my voice.
Yeah, your voice is so calming. Yeah, it's perfect.
There's an app called Calm, so you could be.
So look, now you have the eyes image. It's beautiful. It's really. I'm really happy with the position, and no shoulder. Command range is pretty good covered. Then the compression. How do we assess the compression?
This is a much better image.
It's actually purely a fluoro-based assessment to me. So when do you know the device is not compressed?
Okay.
Well. We don't believe in if you make an echo measurement there, you don't know where, or you can do the 3D function, of course, but then it's reliable. But I will tell on the fluoro, it's very, very reliable. This is a kind of a clock-shaped device, bell-shaped device, sorry. So the device, the diameter of the device, 31 device normally has a depth of half of it, 15, 16. So you would see a rectangle. Here you see clearly the device is for sure as long as the diameter it is. And if that's the case, you have a device of around 20% compression. And that's perfect. 10 is just on the lower end, 30, then it becomes like a hot dog shaped device. Then you have 30% compression. So this looks good. Maybe Niels, I'm gonna do. Yeah, you are doing, in fact, the 3D reconstruction. That's the beauty with the eyes. So in fact, he can get a reliable compression.
So where do you want the compression here?
A little bit lower, tiny bit lower.
Yeah.
Yeah.
Like here.
Yeah, there. And I'm curious now. Normally, this is not something we do, but you can measure there now the device. Yes.
And then we can say from this end here.
Yeah, from that end.
To here.
Yeah, that's on the outer. Yeah, indeed. Yeah, so probably around 27, I think, because they're on the top. You're a bit too out.
I'm a bit too high. So I'm doing another one here. Try from here.
Yeah, from the inside to the inside. Yeah.
And then it's 23.
So 23, 27, 25-ish. So that's 25, 31. That's 20% compression on average. I think that's probably true. I'm going to do a tuck. So if you go live, Niels, a tuck test. Yeah. If you go live, I'm going to do a tuck test now. All right. Good. Happy?
Wait, hang on. I'll just wait.
I'll wait.
Yeah,
if you go like
yeah.
Okay, I go live now. And typically it's a gentle tuck. I'm not tugging extremely hard on this. So this is enough. You see, I'm pulling as long as the well, that small well, is out. So now that well is the well on the proximal part of the device is out, and then this is enough. I don't think it moved at all.
No.
And now I'm pushing the device, and look,
looks very stable.
Push. You see, then I get that well, the well there on the proximal end of the device again. So to be honest, in summary, I think it sits good. Even coaxiality-wise, you see, this is the perfect optimal implant view, REO 50 caudal 10. And in this view, we almost have these 3 markers of the device almost aligned. That means that our device sits nicely coaxial. And that's one of the biggest causes of peri-device leak. If your device is too small or it sits not coaxial, then you start to see peri-device leak. So here we can do a final injection indeed. Quintus proposes that, and I think that's a good proposal. Or maybe a good idea. Yes, all right. Yeah, all right, good. And you see that contrast hanging in the device, that's great, because that shows that the washout, of course, it's still permeable right now because it has to endothelialize. But the fact that contrast keeps on hanging and swirling in the device, if there's a major peri-device leak, typically it escapes within 1 heartbeat and gets out again. So let's move now to echo. Maybe Niels, you have a couple of things to say still on the eyes.
Yeah, I'm just looking at the compression again, and I can do a 3D reconstruction of the device, and I'd say that it's 23.
Yeah, 23. Yeah, so 22. And
from inside to inside.
Yeah,
it's completely symmetrical.
25.
There was no leak past the device.
No, maybe you can go live there again.
Can we see the color, Niels, on the eyes?
Color.
Color is on.
And the color on.
So in general, ice color is much more dramatic than TE color. So if you don't see anything on the ice, there's really no leak.
Yeah, you don't.
Yeah. No, it's true. Same for tricuspid work with 3D eyes. No, look, the 3D eyes, the added value there is especially if you have nicer images, of course. For the transseptal puncture, you saw he had immediately, and he could make an explain, so we could be sure we're inferior, posterior. That's kind of an added value. Then also, of course, for sizing. With 2D eyes, we never rely on our sizing, to be honest. For the eyes here, you can do sizing of your appendage. You can do sizing for your compression. But this is something we don't have that ability for 2D eyes. So here you see the 3D model. Yeah,
This looks great.
We're gonna release it. Yeah, we're gonna release it, I think. So Gintas, do you set the device free? Yeah.
Yep.
All right. All right.
So following up on your comment, as you're releasing, Ola, would you feel comfortable just relying on 3D eyes and also walk away from the CT planning, or do you feel that also that you have too much other information from the CT that makes your CT still valuable?
Very good question, and yeah, I'm leaning, but that's maybe a personal opinion. I'm leaning more to your second statement. I think CT is so fantastic to have up front. You can do complete pre-planning. I mean, it's like you go into the case like at AVI. Yes, you do the whole planning up front. Also, that optimal implantation view. I've seen many operators struggling with it, giving a lot of contrast from caudal, cranial, other view. I mean, you understand the anatomy up front so well. But again, we have done the last 3-4 months. We've done 2 cases, patients who had a poor renal function, could not have CT with contrast. And then we did the case fully with 3D eyes only. And that's totally perfect. And then I relied on my sizing of the 3D eyes. So it gives me the option to do that. And I'm sure if that's your standard, you can do it. But for us, for example, it's such routine now to have a CT before an LA closure that we have it anyway.
Devices are forgiving.
So, Oleg, can I
angio together with echo? So
can I ask as well? I mean, I'm assuming you're not doing TEEs prior to this. You're doing all the screening with CT, including excluding clot in the appendage. Is that correct?
Correct. So we don't. There's no TE that comes in this patient. So it's CT before. Then we do the eyes, 2D or 3D eyes under procedure, and CT post. We do a CT scan around 3 months typically as well. So there's never a TE involved in this whole procedure for us. Yeah, but okay, again, that depends again from your institute to institute.
How good is the CT at detecting LAA clots? Because sometimes I hear, you can't, some people say you can't tell because there's swirling of contrast in the left atrial appendage. And how good is it at detecting device-related thrombosis during follow-up?
Yeah, so clot up front, I mean, it can definitely see it, but it's true that in some cases there's poor contrast filling of the appendage that we've seen. But then, I mean, honestly, on all the hundreds of cases we've done, then you go in, if that happens, you go in the case, you look with your eyes, and if you see on your eyes there is clots, then you can still decide what you do. Typically, in all the cases we've had, that's maybe 10 cases in total, we've actually just proceeded. We proceeded with sentinel filter devices, and we never had any casualty or any problem there. Or you could even take your patient then in that very few cases. I mean, 10 cases on 1,000 LA closures, that's what is it? It's 1%? Yeah, it's 1%. So, I mean, it happens very rarely. And then, DRT after. Well, DRT is extremely good visible on, you can even see that hypoattenuation, so you can have different degrees. My colleague from Aarhus, he even came up with some scale, grade 1, 2, 3, 4 for some HAT or some DRT. So it's extremely visible on CT, better even than I would say DRT than on TOE.
But if you want to see the clot,
you should if you have a few more minutes.
Do you want to have a few
more minutes? There's some questions from the audience, but I wonder, maybe you want to do your final angios and get the system out of the left atrium, and then we can ask you some more questions from the audience.
So here you go. It's sitting exactly the same spot. It's already very good occlusive. So I think we're going to take it out of the left atrium now. Yeah. All right. And please ask any question. But again, I mean, this is... It's really fantastic tools. Yes, I mean, the gear we have these days, these procedures these days take indeed only around half an hour, 25, 30, 35, max 40 minutes, because you have all this with the true steer, the versa cross connect. You don't have to make any changes. These procedures have become extremely slick. It's like a pit stop Formula One.
Like a flexible sheet, use it to align the catheter. Sometimes we use it also while deploying the device. You have to optimize the distal end of the device. In this case, it wasn't necessary, but it's like multiple ways how you could use it.
Yeah, exactly.
So,
it was a very nice Formula One. Yeah, it was a very nice Formula One pit stop, I have to admit, Ole.
Yeah.
Congratulations to all the Copenhagen team. The next question for me is, do you are ready to switch everything with eyes for now? And do you see any advantage of TE guidance for LA closure intervention?
Sure. I mean, TOE is the golden standard, I would say, yes, for most centers and for most people. And I agree that TOE, if you have TOE, the luxury of having it, it's fantastic. I mean, it's easier. But of course, you need general anesthesia. So in my center, working in Copenhagen, for us, the difficulty is getting anesthesia, really. I mean, we only have, the structural team, we only have 1 day a week anesthesia. So we keep these cases for only the mitral tricuspid cases. So all TAVI, all LAA closure is without, we don't have anesthesia. So we do this now since 2011, yes, for how long is it? 16 years we do already eyes-guided LA closure, and very sporadically, we have every year 2-3 cases we still do in TOE, with TOE in general anesthesia, to be honest.
Yeah, it's very impressive. And the setup, you are like 3 physicians as always, and one is fully dedicated for eyes. And like you are now for this live case, or it's another setup in your daily practice?
Yeah, so as said in the beginning, 3D eyes, we need an imager. Like Niels here, we need a 3D imager, and you see he stands on the other side. That's why we also have access here for the vein and the other side. So that's always for 3D eyes. For 3D eyes, when we use 2D eyes, I would say the majority of cases, yes, we do it just alone. So it's me and my colleague or me and a fellow, and we don't have an imager involved. I mean, we're happy if they can, but very often they are occupied with other stuff. They cannot help us. But if they can help us, it makes my life easier. But you can do it completely yourself.
And probably it's majority of cases that we use 2D eyes, and we stand 2 physicians only. That's the typical setup. 3D is a bit of exception right now.
Yes.
Not the full daily practice.
No. Then,
I have a whole lot of questions from the audience for you, Ollie, and your team. If you have 5 more minutes, we have. So one of the questions is, are there cases, now that you've had experience both with ICE and with TEE, are there cases where one is better than the other? Are there limitations of doing this via ICE? Are there cases where you say, oh no, I can't do this via ICE, I'm going to use TEE instead?
Well, look, let me say like that. I mean, in the beginning, when I started doing these cases, that was indeed 15 years ago. I mean, then we had both TE and ICE at the same time. And this is really interesting. I think what I found out is, even now, you commented on like, oh, you're almost too inferior. Well, typically, if you have both modalities, TOE and ICE, the ICE is really, really better to see the extreme inferior aspect of the fossa. Sometimes they miss this on TOE. So when you do TE guided LA transseptal puncture, when your TE imager tells you like, oh, you're really, really on the inferior edge of your fossa, well, switch off your TE ones and switch on your eyes, and you can see you can almost in every case go 5 millimeters lower. And the thing is, an LAA closure is so dependent on successful LAA closure on an extreme inferior puncture. The cases that I've seen that colleagues sometimes send me, fluoros, where they had a failure of an LAA closure, 9 out of 10 of these cases, it goes back to a transseptal puncture who was not inferior enough. So that the posterior aspect is typically less important, or even if a reverse chicken it's even, you have to avoid posterior puncture. I would say, if you go in a majority of cases just central, not posterior or anterior, but extremely inferior, you can do 99% of LAA closures with a good coaxiality. So ICE is beneficial for the transseptal puncture. I like it. I even love that for that. Then, of course, for the implant itself, it's obvious if you have TOE, I mean, and 3D and a brilliant TOE imager, of course, it's even better. Yes, that's clear. But of course, that you need to take the whole package. You need general anesthesia or conscious sedation. You need an imager. You need a probe through the esophagus. So, of course, for the patient now, the patient is just talking. Yes, I mean he's relaxed and he could go in the evening even home. They don't do that. They go tomorrow morning actually home with us, but they could.
Absolutely. So Ali, Karim Al-Azizi, who, as you know, is another huge proponent and world expert in ICE-guided LAA closure, has joined us too. Welcome, Karim. Karim, I'm going to ask you maybe the next question from the audience. We just saw an incredible case of ICE-guided Watchman closure in a slightly complex anatomy with a completely awake patient, right? And obviously, a lot of people, I think, in the audience are amazed by this great case. One of the questions which I think is important is, what is the learning curve for ICE-guided structural procedures? Let's start with LAA closure. I mean, because I think when you start talking about tricuspid, it becomes much more complex. To me, LAA closure is a great place to learn to use ICE. What do you think the learning curve is, and how should operators develop the skill? One of our participants is asking.
Yeah, no, thank you, Azeem, for the question. Congratulations, Ole, on team on a great case. You know, I think the way we've seen this and how we've developed the skill set and how we learned ourselves and taught our co-operators on this, it's probably the first 5 to 10 cases being performed in conjunction with TEE as well. And this way you can turn on the TEE at the time of you're not sure. That's number one. Number two, having an anesthesiologist in the room to control for the anesthesia should you're not really being thoughtful or not thinking at that moment of time, but maybe focused more on the device at the time of deployment while you're so focused on the ICE. And so what I call it as having training wheels on a bike and slowly taking one off at a time. And very quickly, you'll find yourself coming down to a lean team where basically we brought it down to me, my scrub tech, my echo tech, a monitoring nurse, and a nurse for the anesthesia, essentially. And so slowly that comes down. Now, you've asked a very important question. Is this for everyone? Are there different patients that maybe will require TE? We've touched on that yesterday in our ICE LAO discussion with Nicolas, but potentially there are patients that may be extremely restless at baseline. And that's part of the assessment of either taking the conscious sedation ICE-guided route or taking the general anesthesia TE-guided route. And this is how we look at basically approaching this idea of conscious sedation and using the ICE tool as the imaging tool to enable that protocol or way of doing it.
Okay. Great. Ali,
yeah, Azeem, I mean, we can share with, I mean, we started learning this by you doing very simple guidance of PFO closure procedures, yes? And we have hundreds of these to do. So, and it's a low risk, low complexity case. So we use ICE in every PFO closure case. Then we started using it in LAO. So, but it's true, you need some training, of course. It's like everything in interventional cardiology, things become easy and reliable and safe if you do enough volume of it. I mean, doing this for only 10 cases a year, I think it's maybe tricky. I think then I would rather invest in asking for anesthesia and TOE for these 10 or 20 cases you do a year. I think that would be my approach. But if you do more than 50 cases, I mean, yeah, then it's worth investing in getting it. And then if you become experienced in it, then yeah, it's great. It gives you a lot of flexibility for my planning. For example, we can do a case on the Monday or the Wednesday, or I mean, whenever. We're not dependent on an imager. We're not dependent on an anesthesiologist. So the planning becomes as simple. I can just plug it into my TAVI program or anything else. So that gives a lot of freedom, I would say. Yeah.
Yeah. And I think you both made a very good comment on starting with simpler cases and then building your skill set, right? So learning first how to maybe do a PFO or an ASD closure to learn the navigation in the right atrium, and then to maybe move on to transseptal puncture, but with the TE probe there as well, so you can learn to compare the difference. Remember, you can't use both together. You have to switch one off when you're doing the other one. And then to actually doing a whole procedure, I think that's a very careful way of learning. I think there's also simulators. So all the companies, who sell these have a simulator. They can bring it in to your lab and you can learn how to manipulate it and get the views. That's also, an important way. I have two last questions. One is going to be for the entire team to answer, but the first one for you, Ollie, from the audience is, what's the limitation of doing ICE? I mean, is it only the price that it costs so much, or are there other limitations?
Well, the price is the most obvious one. I think I can say. I mean, like the cost of a 2D eye is around around 1,800 euros or something. A 3D ice probe is around 4,000 euros, so it's definitely a cost. But we also have to pay anesthesia on the other hand from the heart center here in Copenhagen, so that still for us it's like a zero operation, I think. So cost is one thing, and the learning curve. There is a learning curve. I mean, you have to be honest, like especially the moments for crossing to the left atrium, that's where most operators struggle with in the beginning. But again, I mean, if you do it very controlled, you never stress out, you take your time for it. I mean, you finally learn it. It's not rocket science, it's neither. So it's you will learn it. Yeah.
Probably in the standard case, Ole, we should say that we use 2D ice in a classical case. So what you lose with ice in a classical case with 2D, you lose the 3D aspect of
That's
it.
why
You
we
don't
do
have
CT up front.
Exactly.
Yeah.
So then we combine it with a CT, which helps to do all the planning and sizing mainly, and we use ice to guide the procedure to together with angio, combination of ice and angio. So that's what you lose. You lose a 3D.
Yeah.
Right. Okay. Well, maybe a last question for the panel, and I'm going to go through each of you and just very briefly. Someone from the audience asked, and I think it's a great question, what is the future of ICE-guided procedures? Do you think, having just seen this, it's going to replace TEE-guided procedures in the future? So if you look to the future, where do you see this going? Guillaume, let's start with you, and then we'll go to Nicolas and Karim.
Yeah, I think in France we are struggling with the reimbursement, but if the device is free of access as a TEE, I think it's really, like this case show, it's super efficient, and the resolution now it's very mature. So I assume that maybe the 4D ICE is the future for a lot of interventional cardiology. Yeah.
Nicolas?
Yeah. I agree with that. There are some restrictions, unfortunately, in terms of reimbursement. Having said that, I see a bright future for ICE-guided procedures of everything that happens above the mitral valve. So in the left and the LAA, maybe some PVL closures, and then for tricuspid procedures, I think all these procedures can be, even today, under ICE guidance and under local anesthesia or conscious sedation. For the mitral valve, I'm a little bit more skeptical for the time being, but it would already be great if we would manage to do that. It would definitely make the interventional procedures more lean, as Ole has suggested already.
Karim, anything to add?
Yeah, no, I think these are all great points. You know, Ole and the team made it look very easy, obviously. I agree with the learning curve, but also more importantly, we have to understand that there is more data yet to come also on the efficiency or efficacy of ICE also in closing LAA and making sure that we don't leave leaks that approaching LAA. But for other technologies, a mitral valve and valve where there are major targets, you're not relying on a lot of leaflets. It can be used in conjunction, but as a standalone, since the technology will continue to get better, I think it will continue to evolve. I want to remind us also that it is not just about the imaging tool, but perhaps the whole approach to the patient, the conscious sedation. Are they truly that level of conscious sedation that they are not deep enough, or are they too shallow that they may be moving during precise and fine procedures?
Yeah, I mean, I'll add to that, because I'm sure watching this live case is not just physicians, but hopefully they're people from industry and inventors and innovators. I think these are first generation devices, so I would love to see next generation devices that allow us even a better field of view. And I'm going to sound like a broken record, but I think AI is going to play a huge part in the future of this, because it will help other people to get better at this, because hopefully with AI we'll learn where to move the catheter, how to place it, how to get the best views. So I think we're going to see a lot of growth in this. Ollie, team,
by the way, Azizi,
we're going to let you go.
Addition,
maybe I see you have some last words before we thank you.
Yeah, the thing is, so I know that even Bos Scientific is working, I think, with Siemens also to an ice probe, which is indeed enough penetration power that you just simply put it in the right atrium and it would have enough far field vision to look into the LAA, maybe do some sizing. So I think in the future, that's maybe to further simplify. Then you don't have to do complex navigation. I mean, if they could do that, then it's really accessible and implementable by everybody. Yes, I mean, you don't need a learning curve. So then even if then that would be fantastic in the future. So apparently they're working on this, so for the LAA field then. And we used, like this morning, the first case today was in a surgical aortic bioprosthesis with the PVL. We did a 3D ICE assisted. We use it in all our LAA tricuspid cases. Tricuspid, we still use TOE, but I think we're close to getting, if we really would have to, we can do also ICE, CT, guided TIR or tricuspid interventions, I would say, as well. So indeed, I think it is indeed the future. And yeah, I hope you enjoyed the live case indeed.
Yep. Ollie and team, I mean, thank you from Copenhagen. Phenomenal case. You really made it look easy. Great result for your patient. And we can't thank you enough. And to our extremely knowledgeable panel, thank you for joining us for this great live case. Thanks, everybody. We'll see you for the next session of TIO 2026.
Thank you.
Bye, everyone.